I'll get on my soapbox for a little bit here and say vital signs are vital for a reason. The registered nurse should be taking that skill back because there is more to assess than the numbers on the vital signs.
This is the Sepsis Spectrum, a podcast about antimicrobial resistance, sepsis, and how to expect the unexpected in your practice. Maya, 17, is rushed into the emergency department by her mom just after midnight. Her temperature's dropping, heart rate climbing, increasing lethargy. The team hooks up the monitor and starts taking a history. But one question cuts through the noise, one we can't seem to answer, and it's chipping away at us. Is it an infection? Is it sepsis? What could the source be? As the symptoms blur, the clock keeps ticking. Time won't wait for us. If we miss the early signs, treatment lags behind. And if resistance is in the mix, let's just say the margin for error disappears. From superbugs to subtle signs, early recognition isn't just clinical best practice, it's how we save lives. And it's one of our best tools to push back against antimicrobial resistance. Hi, everyone, and welcome to the Sepsis Spectrum, or as we like to call this season, Microbial Mysteries. I'm Nicole, critical care nurse, clinical nurse specialist, and your guide through the complicated and sometimes frustrating world of sepsis and antimicrobial resistance. Today, I'm joined by a very good friend and true leader in critical care nursing, someone who's helped shape how hospitals tackle sepsis, infection, and antimicrobial resistance. Kathleen Vollman is a nationally recognized clinical nurse specialist, educator, and consultant. She's trained frontline teams across the country, advised the American Hospital Association, and championed early sepsis recognition at every level of care. Kathleen currently serves as the president of the World Federation of Critical Care Nursing and is the founder of Advancing Nursing, where she's building stronger systems and smarter bedside practice. Let's get started with today's guest, Kathleen Vollman. I am so excited. I am here today with Kathleen Vollman, who is a fellow clinical nurse specialist, but also a disclosure for both of us. We are both truly believe in science and supporting sepsis programs in hospitals. So welcome, Kathleen.
Thanks for inviting me, Nicole. This is going to be a lot of fun and learning as well.
I hope so. So you and I both are clinical nurse specialists, and we both have led sepsis programs in hospitals. And so I kind of want to kick it off just talking about where we are now with hospitals. We're post-pandemic, and I think a lot of hospitals had to do some major regrouping after the pandemic and redirect a lot of programs. And so I just want to kind of get your take, because you do a lot of consulting across the country and even internationally, and just wanted to get your pulse on where you feel hospitals are now with sepsis and sepsis programs.
Well, I'll be honest with you, considering I started this journey in 2004 when the first bundles came out, that we're in a much better place in the fact that with the CDC's programmatic document that came out, and with the government support through quality and value-based purchasing, it has really propelled organizations to see that sepsis is a significant problem in their organization. It's usually the highest rate for mortality for the patients in the organization, and it's also a significant 19-20% readmission rate. And so they're looking at it from a patient perspective, but also a financial perspective. So I think the bar has been raised significantly.
Oh, I absolutely feel the same, because I mean, let's be honest, before the first official bundle and early goal-directed therapy was published, I think a lot of hospitals didn't have anything formal.
No, there wasn't. Everybody believed they knew how to manage sepsis. And both of you and I ran into this. And it was the same with acute myocardial infarction. Prior to the impetus to improve door to balloon, there were system challenges between cardiology and emergency rooms, and it resulted in delays in care. So we've learned from that through AMI and stroke, and we need to put sepsis on that same trajectory of it's sepsis until it's ruled out otherwise.
Yeah, and I think, one of the challenges, and I always say this, is that, we just don't have the 12 lead in troponin for
Right.
sepsis like we do myocardial infarction. And so let's say you're consulting with a hospital and let's say they don't have anything formal. What advice are you giving to hospitals who are starting a journey in formalizing a sepsis program?
Well, one, they need to get a multidisciplinary group together. ED physician champion, as well as an ED nurse champion. They need to do the same in the ICU, hospitalist, lead pharmacist, lab, um, and they then need to identify where they want to start. And usually, because most of the sepsis is identified or come in through the emergency room, that's where I usually recommend that they start. And building screening programs in the emergency room, in triage, I also recommend, and this is fortified by the CDC document, to hire a sepsis coordinator that runs the program. This is a big program. It needs somebody that owns it, and it also needs an executive sponsor at the C-suite level, so that any barriers that they run into, any turf wars, anything that happens, they can use that executive sponsor to be able to push through uh, the whatever challenges they're experiencing.
I think that's actually really good advice for hospitals and sepsis coordinators is to make sure you've got that direct connection with leadership.
Yeah. And I was excited to see that that was also in the CDC, because that was something that, from a consultant perspective, I always made sure that connection existed. And then, really, in triage, having early recognition signs of sepsis, where they're doing a screen, an actual screen, um, where they're asking questions. Have you sought healthcare in the last 2 weeks? Um, is your mom making sense to you? Vital signs, oxygen sat. Do they have a fever? And if they, have a cough, there's things that they can begin to recognize, and they put that together in a screening document. And if it's suspicious enough, that, in my perfect world, because that's where I live and I work really hard to get everybody else to hang out in my perfect world, it would launch a protocol. And that protocol would allow labs drawn and other processes, blood cultures, and that to move forward with the recognition, management, and treatment.
Yeah, absolutely. And I think one of the things that we've discussed in another episode that people don't necessarily think about is, we always associate fever with infection, but truly, when you're working in triage, a low temperature
Oh, yeah.
can be just, if not even more profound, I think, than a
It
fever.
is. It is, because that's basically your body saying, I have used up that inflammatory response and I can't mount it anymore.
Yeah.
And so both sides, same with low white count. The high white count says those guys are out there launched fighting. The very low white count either means they're massively immunosuppressed because of whatever disease they have, or they've used everything up.
Yeah. And I think that's just something we don't always cue
Pay
into,
attention to. Yeah.
Yeah, absolutely.
Well, and one of the things I also teach nurses, um, two things about tachypnea, unexplained tachypnea. really needs to be viewed as a medical emergency because the body's blowing off acid. If you can't explain it, if that's not something that they routinely do because of their COPD or something like that. So, and it's similar to an unexplained hypotension.
Well, can we back her up
We
and
sure
just
can.
talk about just something basic as the respiratory rate is extremely predictive of deterioration?
Absolutely.
And I always say, what's the problem in hospitals? How do we measure the respiratory rate, Vollman?
Oh, it's 16 or 18 a minute on every single patient. The accuracy of it is massively challenging. And I'll get on my soapbox for a little bit here and say vital signs are vital for a reason. The registered nurse should be taking that skill back because there is more to assess than the numbers on the vital signs. There's the way somebody is breathing, the speed of it, the feel of their skin, whether they're sweating. There's so many things that you pick up during that interaction
Yeah, well, and it's very rare that you're going to have a patient who's septic, who's breathing 16, 16, 18, 16. They're often breathing in the 20s and sometimes 30s or
because
higher.
they're blowing off that acid. That's
Yeah.
their emergency way of trying to correct what's physiologically or pathophysiologically going on in their body.
All right, so we've already met two main objectives I want to hit on today. It's just that a low temperature can be as a warning sign, but
Yeah,
also how important the respiratory rate is.
yeah.
Okay. All right, now let's say you're consulting with a hospital as a clinical nurse specialist, and they're really trying to do the right thing. So they're implementing their bundles, 30 mils per kg of fluid. They're getting antibiotics on board. So let's chat about antibiotic recommendation as an antibiotograms. What do you recommend to hospitals from a programmatic standpoint regarding antibiotics?
Well, as part of that committee work, they need to get the ID doc, the infection preventionist, ED docs, and ICU docs together in a room to take a look at what bugs are in the community that are routinely coming into that environment and what bugs are in the hospital for hospital acquired, and pick um, initial antibiotics. And interesting enough, I don't know if you're aware of this study. It came out of University of Michigan. They've got a big consortium process going on with the state of Michigan, and they're sort of like the coordinating center. So they're publishing a lot of research on the 60 or so hospitals that are participating in this. And well, I'm going to ask you, what antibiotic broad spectrum do they usually give?
Piptase, Zosyn.
Zosyn, exactly.
Yeah.
So they did this. So there was a Zosyn shortage, and they captured data on 7,500 patients, even groups, where Zosyn, and then the shortage happened. So they gave, if I'm going to say this correctly, cefepime,
Yeah, cefepime.
and both groups had gotten vancomycin as well because of whatever's going on in those communities. Interesting enough, when they compared these and they matched the populations, 5% higher mortality rate in the Zosyn group
Really?
because it's knocking out some normal stuff that needs to stay, probably in the gut.
Wow. And so was that an observational study? Like, do you think they'll do a randomized control trial or?
It would be fascinating to do it. It was a retrospective analysis
Oh,
of
okay.
their data, and they matched the groups and did the correct statistical analysis to it. But so there's a couple of things around getting the right antibiotic. One is what you talked about, what you mentioned in terms of a programmatic perspective to identify, because the speed at which we give the antibiotic in is important, and the data has shown. But you don't want to just arbitrarily toss the antibiotic bucket at people
Yeah.
because you have antimicrobial resistance. So strategizing the initial type of antibiotic in the septic patient is important. The other component is managing the accuracy of your blood cultures and also appropriateness of urine cultures. Because in the data, 20 to 50% of the inappropriate antibiotics in a hospital are based on inappropriate urine cultures
Interesting.
because they're running it off the WBCs and nitrates
Mhm.
in the urine and not connecting it to signs and symptoms with the patient.
Oh, so they were just reflexively giving antibiotics when really the patient likely didn't need them.
They did a UA that went to a reflex culture. The
Yeah.
culture came up. It was not connected to symptoms, but they gave the antibiotic because the culture was positive.
And from your perspective, what are hospitals doing now? Are they just doing blood cultures, or are they doing like blood plus a urine if they have UTI symptoms, or a sputum if they're having
Yeah,
respiratory symptoms?
I would hope. There's still a lot of pan culturing. The pan culturing happens, I think, more in-house than it happens in the ED. I think the ED is a little more specific based on the symptoms. But from a programmatic perspective, how we manage blood cultures and reducing contamination of blood cultures by how we draw them, and putting very specific criteria for when an appropriate urine culture, when it's appropriate to order a urine culture. In other words, having the provider mark what are the signs and symptoms this patient is experiencing, in order to get accuracy in those urine cultures. So we use our EHR and build that as part of the programmatic development.
And then what do you recommend hospitals do if they are seeing a trend in contaminated blood cultures?
Well, there's recommendation that one, we reduce the number of people that are drawing them so that you can control the process variation, that you do good skin antisepsis, that you have um, the right material present, um, and it's set up the correct way. So in my perfect world, that usually is helped by a kit that has all the necessary activity in there. And then the science that really has come out in pushing down the contamination rates is ensuring you've got some type of diversion device so that there is a passive way to remove the skin plug, skin colonization bugs, so that when I'm getting the blood culture, I'm getting the true blood and more accurate.
Oh, interesting. And do you feel like that has become general practice across the country, or how do you
Well,
feel?
it's improving because we went from a standard by the lab group of 3%, tolerating 3% contamination blood cultures down to 1%.
Oh, okay. So you're definitely trying to get this to where it's a very rare event that's happening.
Because again, contaminated blood cultures, one can either delay appropriate therapy or somebody could start inappropriate therapy or they don't know when to stop it. And so, because there's a wait period for the blood cultures. And so those antibiotics are on during that time. Now, another strategy hospitals are doing, adding to this journey, is the use of procalcitonin for de escalation.
Well, you know what I would love? I would love to let's go to break. And then when we come back, why don't we chat about the bundle and chat about how we, number one, make sure we've got the right antibiotics, that we're not contributing to antimicrobial resistance, and how do we de escalate antibiotics? Are you a nurse, infection preventionist, or healthcare professional who wants to stay ahead of the curve? Visit sepsispodcast.org to learn how you can receive free nursing CE credits by listening to or watching the Sepsis Spectrum. It's our way of supporting you and together better understanding the ever-evolving world of sepsis care and AMR. And now, back to the show. So, Kathleen, let's talk a little bit more about the bundles that we're all using. So, we're getting labs, we're giving 30 mils per kg of fluid. And then, if the BMI is 30 or higher, we can use ideal or predicted body weight to dose fluid. And we're starting ideally appropriate antibiotics, but if not, broad spectrum and then quickly narrowing.
And that narrowing is really important. And that often happens in the ICU or on the med-surg environment.
I mean, we could do a whole episode on phenotyping bugs and how do we find the source of infection. Like that could be its own episode. But let's chat about the bundle. Let's first talk about fluid. So 30 mils per kg. What are you seeing happening across the country? So first of all, let's talk about fluid choice.
So on fluid choice, I'm excited to see it shifting. That the research data that's come out over probably the last 7 years, I think it's been, in the various studies have really shown to us, and a couple meta-analysis as well, that balanced solution is superior in sepsis resuscitation and in most resuscitation other than in neurologic, I believe, is one, and trauma.
Yeah, and just so for listeners who aren't aware, but when we say balanced fluid, we're talking like lactated ringers, plasma A, Normasol, so things that are more physiologically like similar to your own blood and plasma. Yeah, so and that's what where the literature is right now, and there is an open meta-analysis that's going to stay open, and as studies are published that meet the criteria, it's going to be updated, which is super exciting.
Which is awesome. But it was exciting to see. So both you and I were at our national critical care conference, the National Teaching Institute in New Orleans. And it was great to see in the various presentations, and yours was one of them, the number of people that raised their hand that the resuscitation is taking place with balanced solutions. So that was faster uptake than I thought it would be.
Yeah. Well, and for those of you who aren't aware, that one of the big concerns is the chloride in saline leading to kidney injury and other complications. All right, let's chat. Okay, so we're moving toward balanced fluid. Now, what about reassessment of fluid? Like what trends are you seeing across the country with reassessment of like you've got somebody who's hypotensive, do we give more fluid or do we start a pressor? Like where are you seeing that
Well,
heading?
before I want to back up, if you don't mind,
Oh,
just for a
sure.
second. There is still hesitation that I saw out there in audiences and talking with nurses about renal failure patients and congestive heart failure patients not getting that full 30 ml per kilogram. And there is very good data out of Northern California, Kaiser, showing that when they are resuscitated appropriately, with that 30 ml, you may not give it as fast, but it's still within that 3 hours that they have better outcomes. And that has been reproduced in the state of Michigan work as well. So, in other words, doesn't matter what your comorbidities are, they should get that fluid.
Well, it's interesting you say that. I know I just in doing root cause analysis on patients who die within 24 hours of presentation who are septic, it was often we would find a renal patient who's got CKD or a heart failure patient or even both who was under resuscitated.
Yep, exactly. And so the data's there, and we need to pay attention to that and push to have that resuscitation. Then, once we get um, past that initial fluid bolus, usually vasopressors if the patient remains hypotensive, but then at a point, if the hypotension remains, that there needs to be precision assessment of whether somebody responds to fluid or not, using some type of dynamic assessment. Most of the time, what I'm seeing now, I mean, the uptake is greater using passive leg raise with a dynamic assessment of stroke volume. Now, I will tell you, and I want to correct anybody who is doing a passive leg with blood pressure.
Oh, yeah.
It doesn't work.
Yeah, well, blood pressure is just a very static measurement, and I don't know if a lot of people know that like when you do a non-invasive blood pressure, it's not measuring systole and diastole. It's measuring a mean, and then it uses
And
a
then it
reverse calculation to give you a systolic and diastolic number. I'm always surprised at how many people don't know that.
Well, I'm surprised at how many people believe that number versus an art line that works accurately with a good square wave.
Now
That
that could be a
that's
whole
a whole
episode.
nother yes, that could be something on its own.
We're
But
gonna do 20
using
episodes just of our own
yeah,
topics.
using non-invasive or invasive, depending on if your patient's mechanically ventilated and has an art line, or if they don't, then using non-invasive mechanisms to be able to identify patient fluid responsiveness. And usually it's a stroke volume change of greater than 10% demonstrates that they're likely fluid responsive. And therefore, I would tend to move towards giving fluid more than raising my vasoactive.
Well, and what's interesting is in one of the randomized control trials that was published, they showed that they were able to decrease mechanical vent rates by half when they used a stroke volume measure.
And by
It,
the way, CRRT, they
yeah.
didn't have to do. Oh,
Well, and they cut that. That was significant
I know.
reduction in the
Yep.
need for dialysis. I think it was ICU length of stay was cut by 3 days when they use a stroke volume measure.
Yeah.
And it's just interesting. And I just don't understand why we're still using blood pressure and heart rate to guide fluid.
Well, and literally, I think you and I have tossed this out a number of times. Are you going to guess it or assess it?
Yeah.
Because all the other stuff is guessing.
Heart rate and blood pressure.
Yeah. Heart rate and blood pressure, or even CVP, because that's a static measurement. Those are guessing it versus truly assessing the patient's response. And if the world is talking about precision medicine, that is precision medicine.
Yeah, using a stroke volume change with the passive leg raise test. Yeah.
Yep.
Yeah. So, yeah. And for those of you who aren't familiar with the passive leg raise test, do you mind just explaining it, Kathleen?
Sure. So basically, it's it's the easiest way to describe it. It's a physiologic bolus. So basically, you start with the patient in a 45-degree, you let their body equilibrate, you take your measure, and then you put them down and you passively, you don't let them participate at all because that will mess with your reading, and you lift the legs up. And that gives you roughly, is it about 300?
Yeah, it depends on the
250 to
patient's
300?
height.
Yeah,
Yeah, it's about using their own blood,
right.
about a 300 mil bolus back toward the heart.
And so one of the reasons why passive leg raise is a more appropriate choice versus giving a bolus is because we don't want extra fluid on board if they don't need the fluid.
Yeah.
Rather have their own fluid serve as a measure for assessing.
Yeah, and you can just really, like you said, use precision medicine and guide fluid because it's not uncommon to see patients getting, 5 to 10 liters of fluid in the first 24 hours of presentation. When you use a stroke volume assessment, you're given a lot less fluid.
And ultimately, I mean, we used to live in the world of flood them, we'll take it off later.
Yeah,
And we know that is detrimental. There is increase in morbidity and mortality related to that. So we need to follow the science. And as a result, when we recognize them early, provide the right measurements, assessments, and fluid and vasopressors and appropriate reassessment, which is basically doing the bundle, the mortality rate is significantly lower. And that was measured in the CMS data that was published in Chess by Sean Townsend.
yeah. All right, let's jump now to antibiotics. So you mentioned procalcitonin earlier, because again, a big concern we have with patients is antimicrobial resistance. So can you talk about, all right, so you use antibiotograms. That's one of the things when, as a consultant, you're seeing hospitals.
Recommending, yeah.
Yeah. So can you talk a little bit about, okay, let's say you've got somebody who's on antibiotics. Like, do they have to run a full 7 to 10 to sometimes 14-day course, or can that look a little different?
Well, it can look a little different if you do the procalcitonin test to evaluate whether you need the full course, or if the patient resolves fairly quickly, oftentimes 48, 72 hours they're drawing it to see if there is a possibility to be able to get them off, or is something not working?
So, can we talk through what this would look like in a practical standpoint? So, would the emergency department get a procalcitonin level as a baseline, or what does that look like?
Interesting enough, the data that I've read, the Procal, even though everybody draws the research is not there to identify somebody in sepsis, because sepsis can be caused by a bacterial, a viral, or a fungal. So that's really where the technology and innovation is moving to, because what I see now and what I've seen in the research literature is procalcitonin and CRP are drawn. Both of those don't have strong areas under the curve for somebody who just has an infection
Like
or
a
even
viral or fungal or
viral or
bacterial?
fungal or bacterial. They
Okay.
they don't have a good area under the curve for identifying
Oh, for
somebody.
identification. Okay.
Yeah, for the
Mhm.
early identification part. So you're looking at blood draws, MDW monocyte distribution width, abnormality has been it. So most of the they're either blood, the monocyte, the WBC, or a gene expression that is telling us that the patient is igniting an abnormal response to a virus, a bacteria, or a fungal. So it's not specific to a bacterial, which is important because we don't know what it is when the patient first comes in. Um, I will tell you on all three of the ones that are there, the MDW, it's IntelliCept and Immuno Express, they all have negative predictive value of a 0.97.
That's pretty amazing.
So the ability to rule it out is very strong with all of
Oh,
those.
okay.
The positive predictive value is not as high. It's in the high sevens or the low eights, point 0.8. But the negative predictive value is how I would use those tools to say, okay, I know it's not that.
Yeah, well, which would be super helpful, right?
It would be very
Yeah.
helpful.
Because
Yeah.
if you can avoid exposing a patient to antibiotics or antifungal, viral drugs, that would again you think because you've got to think longevity in our population.
Well, and the whole consequence of the amount of antibiotics and the antibiotic resistance in the environment, the impact on the patient of C. diff, the resistant microorganisms that form because of the amount of antibiotics that we use. There's new bugs, resistant bugs that are coming up all the time.
Okay, so let's circle back to because I kind of want to close it out with so how do we use procalcitonin to de-escalate antibiotics?
So my understanding, how I see the practice working, is they may do it 3 days in and then 7 days in, the usual antibiotic time, but don't quote me on that because, um, I usually leave that up to the providers.
Sure. Well, and I've seen a lot of variability.
Have you? Okay.
Yeah, like one hospital I worked at, we did it every other day, and then I've consulted with hospitals that are doing an approach to what you're explaining.
Yeah. So, I don't I don't know if we have the exact, which is why you're probably seeing the variability. I just know it needs to be part of the equation. On the backside, not as much on the front side. That's my personal.
Yeah, and then so we would use procalcitonin so that when the level gets to normal, like, then what?
Take the antibiotics off.
Yeah, so if it's appropriate. Yeah, okay. Yeah, which again will help, right, in the long run.
Well, and, I believe I just read a study, was it New England Journal or JAMA, that they were able to show that for a central line, bloodstream infection, you only had to run it for 7 days. You didn't have to run it for the 12. So it's important for that science to then get into practice so that we can manage the environment, whether it's hospital-acquired sepsis or it's community-acquired sepsis.
Yeah, because if you think about especially antimicrobial resistance in some of our, especially our chronic patients, we want to minimize exposure if it's not appropriate in that patient population, so that down the line we're not dealing with AMR.
Right.
Well, I just want to thank you for joining me today. You're always so much fun to talk to. I always love just chatting with you and just seeing like what you're up to and what the latest
Well,
greatest is out there.
thanks for inviting me for this.
Absolutely. It's always so fun to get to chat with your friends. And, I've known Kathleen Vollman for years, and she's just an amazing clinical nurse specialist who really gets, from a system perspective, how to move the needle and really implement programs so that they matter and make a difference. And, of course, it always is just so important when you're trying to implement something from a system level to get all the right people involved, especially those at the bedside who are actually doing the work. So I just want to thank you for joining me on today's episode of the Sepsis Spectrum. If you like the show, we want to hear about it. Please leave a review wherever you're enjoying the podcast. It really helps a ton. You can also reach me and our awesome team at info@sepsis.org or visit sepsispodcast.org to share any stories of your own, questions, concerns, or any episode ideas you may have. To learn more about Sepsis Alliance, visit sepsis.org. The Sepsis Spectrum is brought to you by Sepsis Alliance. I'm your host, Nicole Kupchik. Our executive producers are Allison Strickland, Hannah Sass, Claudia Orth, and Alex Colvin. Our producers are Aaron Corney, Rob Goldman, Shanti Brook, and me, Nicole Kupchik. Our post-production producer is Tim Scott. Our editor and engineer is Jason Portizo. And our music is by Omer Benzvi. To learn about Sepsis Alliance's podcast legal disclaimer and compliance policies, you can visit sepsispodcast.org/disclaimers. The Sepsis Spectrum is a human content and Sepsis Alliance production. Thanks for watching. I hope you're enjoying the Sepsis Spectrum. Leave a comment below and let me know. If you want to binge some more episodes, just click that playlist right over there. And if you're feeling super generous today, give this video a like, subscribe if you haven't, hit the bell, all the things. And of course, you can also listen on the go wherever you get your podcasts. Bye.